Welcome everyone, and thank you for joining us today. We are 5 of the Maricopa County Department of Public Health dietetic interns who have been fortunate enough to receive the David Schwacke Memorial Scholarship through Sun Produce Cooperative. Over the past 2 weeks, we've been collaborating with Cindy, Dave, Rachel, and Anne with Desert Mission Food Bank to create a solid foundation for a Produce RX program, not only in Maricopa County, but ultimately through the state of Arizona. Our hope is to represent the values and life mission of Dave through our work in creating a foundation for a program like this. We would like to briefly introduce ourselves.
Hi, my name is Maisel Delamy, and I feel like as a dietitian, as my role as a dietitian, I feel like through this program, it represents the missing link among the vulnerable population.
Hello, everyone. My name is Elena Gonzalez, and I see Produce RX as the next step in lowering health disparities in under-resourced communities.
Hi, my name is Sydney Hollingsworth, and I'm grateful to be involved in this program because it allows so many different organizations and communities to work together and serve others in a capacity that has the ability to improve health and well-being, not only in Maricopa and the state of Arizona, but eventually around the country.
Hi, everyone. My name is Chloe Miller, and I'm so excited to be a part of a project like this because not only are we going to be improving health outcomes for those who need access to healthy and local produce, but also we're going to be stimulating the local economy and supporting local farmers while moving Arizona to be a food secure state.
Hi, everyone. My name is Jacqueline Ryben, and I see Produce RX program directly benefiting the students and families I hope to serve through school food service, as well as culturally relevant farm to school programming. Here's a brief presentation overview of what we'll be covering today. So here's a brief definition of what a Produce RX program embodies as an idea as food as medicine. So the benefit of Produce RX is twofold, as it not only allows food and nutrition to be part of the healing and treatment of chronic disease, but it also provides fresh produce to those who may not have it readily accessible to them. Our vision of a Sun Produce RX program, also known as SPRX, which we'll be referring to throughout this presentation, takes it a step further by incorporating the local food systems in order to provide tasteful local produce that has the ability to meet consumer demand for culturally relevant produce. And now we're going to cover some of the background.
So during this presentation, we're going to outline the framework for a pilot program with the mission of incorporating the local food system in the Sunny Slope community and Sun Produce and their partners. Our goal is to create a unique Produce RX program that supports the local food system while offering culturally relevant produce. And a big component of our program that sets us apart from others is our emphasis on mental health. I know that everyone listening to this call is a helper, and that's why we're here. And these are the stories that show us why this work matters. We could go on and on about why we think that Produce RX, and specifically our program, Sun Produce RX, is a great model, but what really matters is the real life impact. A similar style of program demonstrated that the importance of a program like this from both a participant and provider perspective. In this program, impacts range from the increased access to fruits and vegetables, increased knowledge of the importance of fruits and vegetable intake, and reduction of the financial burden that fresh produce can have. For those who need more concrete evidence and like to see the numbers like insurance companies, we have the numbers to back that up as well. In the Houston Produce RX study, their estimated cost of one quality adjusted life year was only $1,300. This is compared to the insurance company willingness to pay of $50,000 to $100,000 for one quality adjusted life year. On the right, you can see here what a systematic review study found, that over the course of a lifetime, $39.7 billion could be saved from formal healthcare costs if we introduced a Produce RX intervention early on. This is all not to mention that impact the local economy a program like ours will have for local farmers as well. So the savings is not only in healthcare costs, but it is putting that money back into stimulating the local economy as well. As previously mentioned, the Houston Food Bank had a great Produce RX program that had many takeaways that we consider for the Sun Produce pilot program. The first aspect that we really liked about this was the warm referral. And this is where we provide warm communication from the referring agency to the case manager in our program. We found that this was vital for participation in the Houston RX program. A warm referral includes an introduction and consistent communication between each stakeholder every step of the way. The next aspect that we really liked from the Houston Food Bank was the Food RX card. This was redeemable for 30 pounds of produce and healthy items twice per month. They also had their distribution center set up like a market, similar to what Desert Mission Food Bank was doing prior to the pandemic. So using this client choice model made this a dignified and more normalized experience for the participants. This is something that we'd really like to incorporate into a future program, as the client choice model is found to be very effective in maintaining participation rates in programs like this. As we talked about with the distribution, so not only did they have market sales, but they also had a variety of ways for participants to receive their produce, including 13 food market trailers, 15 market pantries, and they also had 21 partners making referrals. Because Houston has a sprawl-like infrastructure similar to Phoenix, variety was extremely important to make this program effective. And having all of those different referring agencies also allowed for there to be a greater reach of participation. If you've worked in the metropolitan Phoenix area, you know that reaching people and getting people to the resources can be very difficult. So having this wide variety of referring agencies, as well as places for people to get their produce, was essential for making this program so successful. And the last barrier, or the last aspect that the Houston Food Bank Produce RX program talked about, was transportation. And this was the #1 barrier reported by participants. The #1 deterrent for this program was that not only was there too much produce, 30 pounds twice per month, but that they couldn't get they couldn't get to the produce, or they couldn't bring that produce home. So similar to the Phoenix sprawl, this is a consideration that we're going to touch on heavily later today.
Another program we wanted to highlight that implements a closed loop referral system is Food for Health. The Food for Health project is an initiative and collaboration between Parkland Health and Hospital System and North Texas Food Bank. These agencies, along with hundreds of others, are leveraging the Dallas Information Exchange Portal, also known as IEP, to improve the nutrition of food bank clients with chronic conditions. This IEP utilizes a case management system to gather client data, track goals, and report on that data. When a patient from Parkland who is enrolled in the system visits one of the North Texas Food Bank partner agencies, the food bank case managers will receive a real-time summary of that person's history, outlining the client's dietary needs, so then appropriate nutritional recommendations can be made. We know that a lack of communication and cold handoffs between providers results in patients getting lost and forgotten. By implementing care coordination through this electronic continuity, we can improve health outcomes. There are several anticipated health benefits from this program, a few of them including a 20% decrease in poor glycemic control, a 10% reduction in emergency department utilization, as well as a 5% decrease in the hospitalization rate. There's also an anticipated improvement of service delivery and program quality through qualitative data collected in this program.
And moving on, we just want to present a few key takeaways from the most recent John C. Lincoln Community Health Needs Assessment. As we can see here, the majority of Sunny Slope community members living in Sunny Slope have 2, 3, or more chronic conditions such as diabetes, high blood pressure, cholesterol, obesity, and depression. In this most recent assessment, evaluators highlighted fruit and vegetable consumption as an improvement area as it pertains to the community's current nutrition status. And lastly, based on this assessment, we can determine that the majority of these community members are consuming less than 5 or more servings of fruits and vegetables daily. This is a 8.5% less than the national average, which is significant to note when meeting the community need for fresh produce.
Okay, and now we're moving on to framework and methodology. So this is for the pilot phase. We will be going over the eligibility criteria in the next few slides. So our pilot study specific objectives are to improve overall biomarker status. That would include the BMI, A1C levels, lipid levels, as well as overall mental health status. And we will talk about how we will record this data later on. So our pilot target population, we decided we wanted to go with adults 18 and older, and they must be diagnosed with a chronic illness and reside in the Honor Health John-C. Lincoln service area. So for our pilot inclusion, like I mentioned, they have to have a chronic disease, whether it's diabetes, cardiovascular disease, high blood pressure, hypercholesterolemia. And they must note that they consume less than 5 servings of fruit and vegetable per day. And as mentioned previously, for this pilot, we are targeting those living in the John-C. Lincoln service area. So our pilot exclusion criteria are pregnant individuals, children, those with cognitive disease, and those on enteral or parental nutrition support. We wanted to give other participants who don't have any type of benefit, like pregnant individuals and children have WIC benefits. So we wanted to focus more on the chronic disease population for this program.
Next, we move to the math of all of this. So the sample size calculation, because we don't have a previous study or program that provide us with number, that's why we have the space and to design the sample size and how it looked like. And it was designed through single proportion formula. And in this formula, we'll get to design like all the values. So the precision will be 0.05, that much we are precise in the sample size and the outcome. And the confidence level means we are that with 95% confident and sure in our sample size to meet the objectives. And the last thing that I want to highlight in this slide is the p-value, which represents the prevalence of chronic diseases in the US, which is 40%. So moving on to the next slide, where all this math will be done, and boom, you have the sample size of 365 participants. And based on another study, for a pilot study, we don't need to use the 365 participants. It's only required 10 to 12% of the actual number, and that will be about 50 participants. So the next slide is the just highlighting that all this sample size, how is it translated into the objectives? So the post-intervention analysis, we need to measure the objectives, and then when we measure them, that's how we achieve the objectives. in the next slide. So we're done with the objectives, the sample size. So we have the people, the population that we designed, and just imagine I want to emphasize on the demographic of the population. So sky's the limit, how much we would have data coming back, and how is that translated? It's translated into age groups, males and females. It was translated into like education level. All these things, all these variables will play and then will be presented, means, frequencies, all these kind of things. Okay, moving on to this slide. So what I want to highlight in this slide is we have the center of attention, which is the box, the Produce RX box. It's the intervention. So keeping that as a center, and then all the other variables are how they affect each other. So looking into this slide, we have the box and we have all the other variables, which is the BMI, the LDL, the glucose control, A1C, and then the blood pressure. How does these variables interact with each other? And what we want is, of course, a significant correlation, like a significant association between them, where Produce RX will decrease BMI or will improve blood pressure control, for example. So we're hoping for a significant correlation, but just in case if we get an inverted correlation, it can be discussed in the discussion. Okay, in this slide, I want to highlight like what separate Produce RX program than any other program is it looks into mental health status. And how do we achieve, how do we measure mental health status is through a gold standard, which is a qualitative analysis. So in the qualitative analysis, it's how is it done? It's done through an interview with the RDs or a trained personnel, and this will be translated into through the interview, they will look into number signs, and this can be translated into numbers. And already referencing a model, which is the qualitative pre-test interview, which is based on the CDC Healthy Day Score module, and it's already linked in the references.
Great, so next we would like to discuss the expected outcomes foreseen from this pilot program. We anticipate increased or improved biochemical markers, long-term behavior change, and as was mentioned, improved mental health. We also foresee increased community resource awareness and connection and engagement, as well as increased accessibility to local produce and then the quality of that local produce. And lastly, we would love to see an increase in fruit and vegetable consumption overall, and then number of meals prepared at home. This program will not function well, if at all, if each stakeholder isn't involved in the process and progress. Here are the key stakeholders, and I will review each of their roles. Sun Produce and farmers will, of course, be selling and providing the food that'll be in this program, acquiring continued funding and program development in conjunction with Desert Mission Food Bank staff, also known as DMFB. Honor Health and DMFB will house the program's care coordinators and staff, as well as the education resources. They will administer food and also be a funding source. Pinnacle Prevention has a great program known as Pots to Love, which would be a great resource for our program. They also will assist with grants for pilot and permanent programs, as well as advocacy. We have our participants, our eaters, who will be receiving the boxes of local fruits and vegetables, participate in intake and follow-up appointments, and attend and utilize education resources. Next are our clinicians. NOAA physicians and RDNs will refer clients and patients, participate in education regarding our CPRX pilot program. And then lastly, so important to have our community health workers and Maricopa County Department of Public Health who will help connect participants with resources and support funding and resource acquisition. As future dietitians, we want to emphasize the important role we play as a profession in this program. In the role as program director and coordinator, the dietitian will assess and work with participants on intake forms, collect the anthropometric measurements, specifically with our uninsured participants, coordinate and oversee nutrition education through different platforms, and develop recipes based on participants' preferred food choices and available resources. To reiterate, increasing and improving the communication and collaboration between health professionals is essential. Here we've mapped out how everyone works together as stakeholders. As you can see, the workload is divided and spread throughout each organization. Relationships are key to the program's ability to last throughout the years. We have also included ASU in this web to demonstrate what a future partnership would look like, and we will go into more detail regarding this later in the presentation. Next, we'll discuss the flow of the program and how this program will look during launch year. In the SPRX program, we've outlined several steps. First is the referral process. This initial step connects the participant to the program. Next is intake. This is where SPRX staff collect participant data. Third is the prescription. The prescription is filled for each participant, which essentially is the box of produce. Fourth is the education. This connects the participant to educational resources and ideas, so they can then utilize the produce they've been given. Next is receiving the prescription and box of produce, and this is where the participant will be able to use their fruits and vegetables. Following the prescription is education. This connects the participant to educational resources and ideas, so they can then utilize the produce they've received. The receiving process is where the participant will connect to the produce and receive their prescription. And then data collection is where the produce and education are connected to a larger community.
Okay, now we will be going over the recruitment and intake, months 0 to 3. All right, so some of our strategies that we want to implement to get the program started would be to first get our providers involved and on board with the SPRX program. So providing education through webinars, in-services, emails, flyers, and infographic campaign. And in the next few slides, we'll show you a little bit about what that looks like. Hiring staff. So this includes hiring passionate registered dietitians, case managers, community health workers to assist in the coordination of care. Academic involvement. This will look like collaborating with Maureen McCoy, the Food and Nutrition Entrepreneurship Degree Director at ASU. And of course, incorporating local farmers. This will benefit them a lot. Utilizing the grant funding to purchase bulk produce for the program, support small farmers via the Sun Produce RX. Also assist local farmers who can donate produce in exchange for tax credit. And then also developing digital resources for patients that include farmers, local produce education, and cooking demos with local food. Next, yes. Okay, and these are some of our program education materials. If you see on the left-hand side, you see the infographic. This will be given to the providers to learn about what Sun Produce is all about, how they can refer, and some statistics of why it matters. The middle flyer is what will be given to participants. So what they will see, and we'll talk about that later. And then we have our social media templates for our social media. Okay, meeting the staff. So for this program, we want to hire on 2 dietitians because we believe the dietitians are essential in this work. So we have a full-time dietitian who we prefer be bilingual just because we predict that our population is going to be Spanish speaking. And then we'll have our dietitian education coordinator who will oversee the education aspect of the program. And then our case manager and our community health workers. So our case managers will assist with the coordination of care, referral management, addressing any program barriers, and community health workers who will be working part-time will assist with education delivery, coordination of care, packing, and distribution of the Sun Produce RX boxes. And then our program coordinator, our dietitian, full-time dietitian, will oversee all of this. So the referral process, this is connecting our participant to the program. So providers, RDNs, case managers, and community health workers will facilitate a warm handoff from provider to program. So in the case of this pilot phase, people are able to self-referral. So we want to make this process as easy as possible, and our staff will be there to help along the way. And these are just some of the examples of our referral forms. We did create these in Spanish as well, just to make it easier for our population. All right, and next we have intake. So how will we be collecting our participants' data? So this is important. So our Sun Produce staff will work alongside the participants, and they will assess for ACEs, social determinants of health, and other needs through a series of surveys and questionnaires, which we will show you how those will look like in the next few slides. Next, we'll move on to intervention.
So moving into the intervention piece of Sun Produce RX. At the beginning of the intervention, it would be ideal to collaborate with local grocery retailers like Sprouts through their Healthy Community Grants in order to supply our participants with staple cooking supplies such as spices and cooking oils. Our goal is to make sure all participants have the necessary resources to prepare their produce to be extra flavorful per their personal and cultural taste preferences. So when participants receive the Sun Produce RX box, the primary access point during launch year will be facilitated through Desert Mission Food Bank. Later in the presentation, we will touch on our planned post-pilot phase of accommodating transportation barriers long-term. But during this pilot phase, the program case manager will actively connect participants to existing transportation resources as needed. Our goal is to also provide each person bi-weekly, each program participant with 10 pounds of produce. And we also want to be inclusive of the program participants' family size. So our goal is not only to provide produce to these individuals enrolled, but to also be inclusive of the participants' households, such as children, spouses, elderly family members that live under one roof. So what does a Sun Produce RX box contain? So these boxes will provide access to our program participants to local in-season produce that these community members otherwise don't have regular access to. Also, another major advantage of partnering with local farmers through Sun Produce Cooperative is the ability to meet participant cultural food preferences in order to increase their daily fruit and vegetable consumption per their own desires, needs, and wants. So not only are we sourcing this produce locally, we're also providing more tasteful produce that meets participants' cultural food preferences. So in each Sun Produce RX box, we will be providing our program participants with comprehensive education handouts, recipe cards, and feedback surveys. The produce resource cards will be printed and placed into each box to help educate participants on how to make the most of their produce at home. Also, we will be providing these resources virtually too, but we also want to make sure the program participants are receiving these resources at the time they fill their prescriptions. Additionally, recipe cards will be developed based on this local in-season produce that will be provided in each box while being mindful of the kitchen equipment and supplies program participants have at home. Program feedback surveys will also be made accessible to our program participants in each box and also virtually, as we want to make sure that we're providing our participants with the platform to share their feedback of what's working, what's not in real time in order to really meet their needs while they're in our program. It is our goal to provide comprehensive nutrition and culinary educational offerings that will meet the participants where they're at. So this could be in-person, virtual, and will not only be centered around food and cooking, but will also promote lifelong behavior change and skills as well. For example, on-demand video and resource library, printed out educational handouts, as well as culinary skill demonstrations. Really, our goal is to build up our program participants' toolboxes with the skills they need to benefit most from their produce prescriptions.
Okay, moving on to data collection and analysis, months 9 to 12. So in this slide, we highlight the evaluation strategies communication. The first one is communication. So in communication, we just want to make sure that we are communicating and closing that loophole with the stakeholders or the organization for future plans. The next one is community needs assessment. And in this assessment is how we assess the, highlighting like how when we will have a population, we will know what the population is. How does it look like? What are the needs? What are the barriers, which we will discuss in a further slide. And the next one is re-evaluating the program. So once we have, it's based on the community needs assessment. So once we evaluate the program, we will know where we need to improve and how we move forward. Then the last one is care coordination, which is taking what we learned in the previous processes of the community needs assessment and the re-evaluating the program, and then deciding how we move forward. Okay, in this slide, it's a review of the stages of the pilot phase. So it's already covered in the previous slides, but we just want to highlight where we're at right now. So the first step, before we're already done with the referral and the intake. The first one is evaluation, where the participants will be evaluated and then given a set of questions and interview and all of that, and it's already covered by Sydney. The next one is the intervention, which is all about the box and what's in the box. So the receiving the box and the piece of education, it's already covered by Jackie. And then the next one is the data collection. So now we already passed, the participants already took the box, they took the piece of education. So we want to evaluate. How is this? Did it affect them positively as we're hoping? So it will be done through SPRX follow-up questions, and the other side of it is the qualitative, which is done through the interview. The next one is the analysis. So once the participants already took the questions or the interview, we will have so many data to analyze, and sky's limits how many graphs we will have, how many things we will know how the population look like and how to improve. What do we need to be assessed? What do we need to be done? And that's all of it is moving to future plans. So how do we connect all these dots, missing links, that how to improve and how to meet the proposed sample size of 365. So thinking ahead, program consideration. After we're done with the evaluation and all of that, we will consider some stuff. And what we're proposing in the next slide is some of the barriers that the program might face, because it's based on when we look at other programs, other research articles, other studies, how these programs faced a certain barriers, and most based on Walker 2010. It's a systemic review. It's already linked in the references. The two major barriers are language and transportation. So language, several research articles investigated barriers to food programs such as SNAP benefits, and they found out that limited English language skills is the major barrier to program participation. And the next one is the transportation. The lack of transportation is a real concern. Assessing food, especially among low-income residents, and in this case might be our population, they might not have like they can't afford the cost associated with that transportation.
To address these barriers, we've created 8 different methods that we believe would improve the program if implemented over the next 3 years and on. First, we'll start with months 12 to 36. As Mays mentioned, transportation is a huge barrier. So we believe partnering with Metro Valley or other public transportation, similar to the way that Farm Express does, to assist those with transportation would be critical. Essentially, we would be creating a mobile market. Next is electronic cohesion, a closed loop referral system through something known as community care increases program efficiency and success. Access is currently making progress with this program, and we hope SPRX can utilize this in the future as well. Our next solution is Box to Produce Pass. This will allow participants to receive their box conveniently via these mobile options. And this Produce Pass system would also be increasing efficiency of the program so we can reach a bigger market. And lastly is volunteer coordination. Collaboration with community outreach programs such as Hands-On Greater Phoenix to expand the program would be essential. We had the opportunity of seeing the importance of volunteers at St. Vincent de Paul several weeks ago, and again at Agritopia this week. These 2 other organizations are able to do all that they can because of the help of their many volunteers, and we hope we can reach that status as well. These strategies focus on creating relationships with other organizations and programs that would greatly benefit SPRX and allow it to keep running long-term.
So now that Sydney has covered what we could do after the first year of this program, let's talk about bigger plans that we see happening after 3 years in the program. So as Sydney had mentioned, we wanted to move from a box to a pass program. And we see in the future, we can move from a produce pass to a card. So not only would having a card help with tracking program data, which would be essential for insurance reimbursement, which we hope this program will be able to do in the future, but it would also increase efficiency and it would normalize the process. So we envision a Produce RX card that would be similar to the SNAP EBT card as they moved from food stamps to the EBT card, which added to a more dignified, normalized process of receiving food assistance. Next, as Maze had discussed, another barrier being language, we would look at our mini community needs assessment and see what other languages or modalities we need to transform all of our resources into to make this the most successful program possible. And next, we'd love to see academic partnerships. So this would be a symbiotic relationship between some of the academic institutions in the Valley that would be able to provide students and interns with real hands-on experience through providing biometrics. They would be able to provide education and get that kind of hands-on experience that's not offered in a traditional education program. And that would also allow us to cut costs, build relationships, and create a better, more well-rounded network. And then lastly, we would increase education access. So over the last couple of years through the pandemic, WIC has moved to doing phone education for some of its participants. And because of that program has been so successful, they're moving to make it a more permanent education modality. So being able to hire on the staff or volunteers to provide education access over the phone would not only help us reach people who don't have time constraints, but people who also have unreliable or no internet access as well.
So moving on, we'll be discussing some of the funding opportunities for Sun Produce RX. So as we can see, a lot of current produce prescription programs really hone in on maximizing short-term private and public grant opportunities, but these opportunities will not sustain long-term. So our goal with Sun Produce RX programming is to really invest in long-term diverse funding opportunities, such as securing Medicare and Medicaid health insurance benefits. So to be able to reimburse these produce prescriptions through insurance. Also healthcare networks. So as we're beginning with and launch here with Honor Health, that's a good example here in the Valley. Also Banner, there's a lot of different examples of how we can get healthcare networks on board and their support through different foundational funding and to really get buy-in from healthcare. Next, we have federal food assistance programs such as SNAP and WIC. So having a Produce RX program benefit that's integrated into these existing food security programs as an extra benefit for those who are currently clients and recipients of federal food assistance. So this could be a great bridge to gap in as a way to prevent incidents of chronic diseases. And lastly, we have public health program funding as another good revenue stream to look into for long-term funding. Is RX programming here to stay in Arizona and Maricopa County.
These are some of our grant funding possibilities listed here. So we have our local food purchase assistance cooperative agreement program. We have the Gus Schmalscher Nutrition Incentive Program, also known as GUS-NIP. And also we have Blue Cross Blue Shield of Arizona, and lastly, SNAP-Ed. So now we're moving into policy and advocacy. So the following recommendations come from a recent Produce RX policy strategy report from Harvard Law. And this connects produce. So one of the recommendations was to broaden coverage of produce prescription within Medicaid and Medicare. So connect produce prescription programs for reimbursement from Arizona, Medicare, Medicaid plans. And here are just a couple of examples of different reimbursement outlets that we could utilize to fund Produce RX long-term. So we have Medicaid state plan opportunities. We have Medicaid waiver opportunities, Medicaid managed care opportunities. And then the next slide, it goes on to Medicare and Medicare Advantage.
Next recommendation that we really resonated when developing our foundation for Sun Produce RX is part of this food as medicine pyramid. So this pyramid really outlines the spectrum of interventions that are currently in our system and that how they can link that important preventative piece between nutrition and chronic illness. So at the bottom, we have our emergency and federal food assistance programs like SNAP. And at the top of the pyramid, we have that treatment piece, which is really that clinical medically tailored meals. And we really see an important piece missing in this puzzle, which is a produce prescription that really bridges the gap between prevention and the treatment phase of when chronic diseases reach a stage that needs more care regarding food and nutrition.
To summarize the previous slides, food as
Medicine.
Healing.
A human right.
Our revolution.
Thank you.
Thank you.
Thank you.